afternoon, everyone. My name is Danielle Hersey, Maine State Director. Thank you for joining us for the second New England QIN-QIO Healthcare-Associated Infections Collaborative webinar. Before we get started, I'm going to quickly review a few housekeeping items. This webinar will be recorded and the presentation will be available within a few business days after the webinar. I'll provide you with details on accessing the recordings at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and I will provide you with instructions on how to unmute your line. Now introduce our speaker. Joanne Chapman is a MSN, MED, RN, board-certified nursing executive. She is the Director of Professional Practice and the Magnet Program Coordinator at Maine Medical Center. She obtained her BSN from Boston University, her Master's of Science of Nursing from the University of Lowell, which is now the University of Massachusetts, and her Master's of Education from Worcester State College, which is now Worcester State University. Joanne has over 35 years' experience as a nurse leader, educator, and practitioner. She is the co-chair of the CAUTI Committee at Maine Medical Center and has held this position for 3 years. Please welcome Joanne Chapman.
Hi, I'm glad to be talking to you about our Journey of CAUTI Prevention because it has been truly a journey, and I'm hoping that everybody can hear me okay as I go through this presentation. And I apologize ahead that I have a little bit of a cold, so if I do stop to cough, please forgive me. So, the objectives of the presentation are really to talk about some best practices to reduce CAUTIs in your organization across the continuum of care. And develop the interprofessional team's role. And I think I can't state enough how much this is not just a nursing phenomenon, but everybody owns a role in CAUTI prevention, and we'll talk about that. And then how do we engage that interprofessional team in the prevention of CAUTI? So first of all, I am very proud to be a nurse at Maine Medical Center. And at Maine Medical Center, we work within our professional practice model, which is a partnership model, and we have strong shared governance, which leads to practice excellence and excellent care delivery. And we practice with the patient and family at the center of care with every single thing that we do. And with CAUTI, this is no exception. We need to realize that an indwelling catheter is a foreign body or a foreign object in the body. And at any time you put a foreign object in the body, it could lead to healthcare-associated infection risk. And that's really been our mantra, is that no CAUTI equals no catheter equals no CAUTI. And again, by thinking about the patient in the center, we've been able to do some of this work. The other big piece is that culture really has been the key to this. This is changing the culture. And back in 2007 and 2008, we were one of the first hospitals to having nurse-driven protocols. But once we stopped having our meetings, culture slipped back, and no one really paid attention to the fact that a patient had a catheter, plus it was also easy. Removing catheters is hard work, and it is hard work for the patient, because now they have to get up to the bathroom. It's hard work for the caregivers to, sometimes the patients are incontinent, to continually clean them up. But we have to change the culture that it's not about the staff, it's really about the patient and what is the best way that we can keep them healthy and free of infection. So at Maine Medical Center, we had been doing this work in 2007 and 2008. And we had about 78 to 80 CAUTIs per year, which wasn't too bad. But again, remember, definitions have changed along the way. But in 2012, our CAUTIs, the rate and the number of infections and our catheter days just shot up. 2013 is when the National Patient Safety Goal was put into place, and we knew that we had to bring our team back together. And as a director of professional practice, I was tasked with the director of accreditation to lead this initiative to see what we could do to begin our journey. And that's what I'm going to describe to you over the next 40 or 45 minutes about how we've gone and even lowered our numbers even further. What's important to see, what you saw on that other slide, is the number of catheters that we started to use. And our first message was, do we really need a catheter? And we have really worked hard since forming this CAUTI committee to get our catheter utilization down. And you can see over the last 2 years, we have decreased our catheter utilization by over 50%. We went from 0.28% to 0.14%. So, as you saw on the slide earlier, we had 80 infections for 2014. Our hospital administration, in partnership with the CAUTI committee, have set out a bold goal to reduce catheter-associated urinary tract infections by 50%. Well, that's great. CDC and HSN goes and changes the definition in 2015. So now we have a dilemma to how do we compare apples to apples, and there's really no comparison of apples to apples because, as you know, with the new definition change, they've taken out the yeast and the fungus, but they've also added the day of infection to the first sign, and also the 3-day rule before, the 3-day rule after, and then that 14-day window. So it's very hard to determine, if we look at the 80 infections that we had last year, what the number really should be that we're going to go to decrease by 50%. So we've left our goal as 40 infections, and actually we really want 0 infections. We are not there yet, but that's what we're working to, and really a bold challenge. So in 2013 is when the National Patient Safety Goals by the Joint Commission came in place that said that we had to have a robust plan in place to address the issues with catheter-associated urinary tract infections. As we said earlier, we're also a magnet hospital, and CAUTI infections are something that we track for magnet. And our Maine Medical Center also put it on its hospital annual improvement plan, and we also put it on our nursing strategic plan because this is a huge patient safety concern. And in 2012, as I said, we knew we had gone in the wrong direction, and it was time to shift the culture and really begin to think about who had catheters, which is a huge, huge culture change. So in 2012, when we started, we really did not have, we knew we needed an interdisciplinary team. The team that was in place in 2007 and 2008 was nursing. This time we knew it needed to be more than nursing. We needed frontline providers to be on board, both advanced practice and physician providers. And we really needed a physician to be the co-chair along with us. We knew from accreditation and from nursing we could help do a lot of the legwork, but we really needed to have a physician that could go talk provider to provider about what was needed. And we got lucky. We had a hospital that was willing to take that on, and the first year he stayed arm in arm with us. This was also important as we went to look at order sets, because they're provider order sets and you needed a provider sponsor. So even though we could help manipulate the way we wanted these order sets to look, we still needed to have that provider backing behind us. We also needed every department, every nursing department and every other department like MRI, radiology, transport to be part of the team, which included both RN, techs, and nursing assistants. And our biggest key stakeholder that we had to have in place was the supply chain, because they helped us look at all of our products, standardize all of our products, bring new products in, and find them in a cost-effective manner that we can continue with best practice, because we did change a lot of things. So lesson learned number 1. When we first started, we got bits and pieces, but we really needed to have a full team. And I would really encourage other people to include patients and families on this team, because they have a different perspective than we do as caregivers. We do not have a patient and family member at this time, but we are planning to expand to having a patient and family member on that team. And when we recruit team members, we have them sign the charter to what they will be responsible to do, which means that they are going to be active members out on their units, doing monitoring, measuring, and bringing feedback back to the group and being the voice of their unit. And then lastly, you need strong administrative support. And anything to do with CAUTI and CAUTI, all we have to do is ask, give the recommendation, and we have been able to, over the last 3 years, secure 40 more lattice centers, which is a huge capital investment. So I think that is huge. But again, having the rationale for why you want the items and having administrative backup is huge. They've taken a lot of barriers away from us. So our program really follows the cycle of the catheter, from catheter placement to catheter care to catheter removal to reinsertion and that criteria around when we have acute retention. And first of all, number one, we don't want to place the catheter at all and get into that cycle, and that has been our mantra for the whole time. The second thing I want to highlight is that when we practice at Maine Medical Center, we use a collaborative model for evidence translation. We do nothing in isolation. We always start by reviewing the evidence, and we have our partners on the research council help to read the evidence and grade the level of evidence. For example, one of the trends, or not necessarily a trend, but there was one article that published about chlorhexidine pericare, which is used in some places and some places don't. But when we were able to look at the strength of the evidence, we found that it was not strong, so we do not have that incorporated into our practice. So we look at the research, we look at the evidence of what's strong evidence, and then we look to see how we're going to implement it into practice, and then, importantly, how we're going to measure it and continue to make changes. And with CAUTI, there are continual changes as we see more and more evidence. So 2012, we really had to do that evidence review that I just talked about. We had to look at what our current state was and what the barriers were. And we really did this by going out and talking with people and just engaging them in the conversation about, oh, your patient has a catheter. Why do they have a catheter? What are you doing? How do you care for it? How do you do pericare? What do you do before? What are the steps that you use for inserting the catheter? And, you know, we had done a lot of work, 2007, 2008, maybe a little bit in 2009. But we had sort of taken our eye off the ball because we thought it was standard practice. And what we were realizing was that we really needed to regroup with everybody, look at the policy, look at the reasons why we were putting catheters in, making sure everybody was on the same page, look at a standardization for insertion, standardization for care and maintenance, standardization for compliance with the bundle, and what is the bundle, and standardization about how we even took urine samples off of Foley catheters. Even though we had some of this in our policy, it wasn't being followed. Our next level was, what do we do if the patient has retention? How often do you straight cap? When do you put the catheter back in? What are our other options for dealing with the retention? We really had to look at that and focus on that in our action plan. And then we had to look at our supplies. When we were reviewing best practice based on the evidence, all the best practices talked about having pericare prior to insertion of a catheter, in addition to the betadine swab. That our kits did not have any material in them to help us perform that pericare. So we were able to change our standardized kit, and we've now upgraded them twice since 2012 to find the best items. We also went with the smaller size catheters that we could, and so that meant removing all the 16 French catheters off the unit and only supplying 14 French catheters. And then we needed to look at the latex issue to remove some of the latex catheters in some of the areas. We also knew that units were sharing bladder scanners. You would have to hunt and gather to find a bladder scanner, and there would be one shared between two units. So we knew if we were really going to be focusing on bladder scanning and taking assessment and taking those catheters out, that we had to get frontline staff and told they needed to do the job. So we started by looking at the indications. What I want to tell you up front is that our indications are based on the CDC 2009 indications. However, we have left one off on purpose, which is the immobility criteria, because we feel that that can be covered under the perioperative use. So if there's multiple fractures, they're often going to surgery to repair some of those areas, and that's where we put that perioperative use. So for perioperative use for selected surgical procedures, so change number one was for surgeries under 2 hours in length. It was not indicated. That was a huge culture change. So the hip surgeries, the knee surgeries, that automatically used to get catheters, we're now saying you can't get catheters. Some of the quick surgeries that had catheters, we're saying you can't have catheters now. And so there was some trial and error, and we had some surgeons that were willing to try this, but in the middle of the case, the patient urinated on the table, so we had to talk about alternatives for that so that didn't happen again. But again, this was a huge change. The second indication is strict I&O monitoring for critically ill patients. And if we monitor this on a consistent basis, we find that this is the number one reason all patients have catheters with strict I&O monitoring. So we put the piece that if it's critically ill, I&O means you're going to do something with the I&O every hour. Not that you're going to do something about it every 8 hours or every 4 hours, but it really meant that you had to monitor it carefully for every hour. And if you did not need to have hourly measurements, that we would encourage you to use something different. Acute urinary retention and obstruction not controlled by other means. We really advocate for urinary retention to straight cath with the smallest size catheter possible. However, if there's any pain or discomfort or bleeding, we really want to encourage the nurses to have a conversation with the provider. And continuous straight cathing may not be the way to go. And in that case, we may have a catheter placed. Perineal wounds for incontinent patients. And so that was one that if you had a perineal wound, it didn't matter if you were continent or incontinent, you got a catheter. And now as we tighten the guidelines, we added the incontinent piece. We also looked at end of life. If the patient really needs it at the end of life, it is a relative indication. And if they don't need it, we don't encourage them to put it in. If somebody is on comfort measures and death is imminent, we also discourage culture taking from the catheter. And as I said earlier, the guidelines for prolonged immobilization are not on our guidelines, but that is in the 2009 definition. So we had to get on board. So we had to really look at our evidence-based policy and procedure, and we had to vet it with providers across the continuum of medical, surgical, and the different surgical groups and the different service lines, and we had the mantra to get the catheter out. Because if you don't have a catheter, you're not going to have a CAUTI. And why do we want to put an invasive device into that patient? We pulled back out our nurse-driven protocol, which was evidence-based. And we developed the Audit set with the rationale. And again, we needed, for the Audit set, we needed to have physician backing. So that is really where we went behind the scenes and talked to the docs that could make this happen so that they could understand. And because our Audit set is Maine health-wide, we not only have to do this work within Maine Med, but we had to go across our whole system. So we opened up all of our meetings to anybody who wanted to come across the system, and they had a say in the guidelines. And we had to look at our retention protocol, because just because you can't void doesn't mean that you need a catheter. We can straight cast and then continue to straight cast if there's no reason that is safer than putting the indwelling catheter in place. That does take time, because you need to bladder scan. You need to try to help the patient to void. If they can't void and there's more than 300 cc's in the bladder, we are straight casting. And then we needed to make sure that we have the correct kit for indwelling, as well as the right kit for doing straight catheterization. We had every single nurse, anybody who puts in a catheter, had to do education and a read demo for insertion, and we had everyone do care and maintain competency across all of the disciplines. Every week, we put out a different tip of the week. Sometimes we repeated them, but we really wanted everyone to know what we were talking about. What was the bundle, and what were they going to be auditing? And then we got bladder scanners on the unit, and we rolled out education. And one of the things that we did learn is that you have to roll out education almost every 3 months, because they forget some of the little details of what they have learned and how to set the bladder scan. But most importantly, what we did every single solitary week is that we went out and we continued to talk to the front line. We went out day after day after day to talk about catheters, to the point where we weren't asking questions. They were telling us, oh, I had a patient in so-and-so room and he had a catheter and it wasn't indicated, and we don't need this anymore. So I think that is a real key to be visible in this effort, and that every single nurse can talk about our quality goal of decreasing catheter-associated urinary infections, and that's always been our goal. This year, as I said, it's a little bit older, moving forward. I'm sorry that this is a little bit blurry, but we have EPIC, and this is how we built our audit set, which automatically defaults to the nurse-driven protocol. If the provider should say, I want to tell you when it needs to be maintained urinary catheter until provider discontinues, they now have a hard stop, where they have to put why they want this hard stop. But we really want to point everybody in the nurse-driven protocol. Evidence clearly supports when the nurse is in control of removing the catheter, you have less infections. Again, this is a huge culture change, and we have to have baby steps to get there. So, lesson number 2, we need to talk CAUTI all the time, and we really do. We also send out daily reminders. We look at every single catheter on a daily basis and ask if it's indicated. And education has to not only be for nurses, it has to be for everybody, and it has to go out. We've made YouTube videos, we've gone to grand rounds, we have gone to council meetings, we have gone to a variety of forums so that everyone can hear the message a number of different times. We were just getting ready to roll out another mandatory education on CAUTI. This was a little bit different angle and focusing on different items. But we keep it mandatory every year, not repeating the same thing, keeping it fresh. One of the things that we found is that nurses are not always empowered to use the protocol. Even though we have the nurse to discontinue, we have found that nurses still call the provider and say, can I remove it? And one of the things that we've really had to work on, and one of the goals of our hospital, is a culture of safety with respectful communication, is how you have that conversation with the provider that is respectful. Unfortunately, 1 or 2 nurses might have had a bad experience in discontinuing a catheter when the physician was not, or provider was not happy about that. So and they were not respectful in that communication, so we've worked on that and taken that barrier away. And again, this is not a nursing-only initiative. Everybody needs to be included. So that was the end of year one. As you saw, we went from 132 down to 102. And we had decreased our catheter days from 43,000 down to 25,000. So we had made some great progress. And as you know that, as you all know, the rate is the number of infections over the number of catheter days. It was somewhat discouraging that our rate had gone up, even though we had taken out a lot of catheters. So for 2014, we continued with the same mantra, and we've not given up. But what we added is that daily auditing and discussion on how to get the catheter out. And it's been hardwired into our interdisciplinary care rounds. So we will push out every day. These are the people we know that have a catheter. These are the indications that we feel this is not indicated. Can you talk about it? Can you talk about reasons why we need to keep the catheter and why we need to get the catheter out, or alternatives to using a catheter. We also began looking at the straight catheter protocol because we were hearing anecdotally that staff said, oh, wow, I'm really just straight cathing all the time. So we put up a very simple index card that just says on the top, date catheter used, what time did you bladder scan, how much was it, did you straight cath? Then the next time you bladder scanned, and did you straight cath? So we could see how often they were doing it and then what their rationale was. We only kept these cards for 2 weeks. But one of the things that we saw when we started tracking this protocol is that people were waiting every 6 hours to bladder scan, and our protocol said every 3 to 4 hours. As we talked about, we continued to upgrade the order sets that have hot stops, that have rationales in them. And then we began looking at alternatives to inflow and catheters. You know, getting new quantum catheters that work better. So having a front end that trial different products and choose the one that works the best. We are on a quest to look for female quantum cat, which is an interesting product, and I'm not quite sure how that's going to work, but Hollister does make a product, and it's sitting on my desk right here. We also got bedside scales. Every single bed in the intensive care unit has a bedside diaper scale, and that way we can weigh undergarments, and it's a 1 milliliter to 1 gram conversion, and that is how we measure accurate INOs, and we also deliver them to every nursing unit, so they have 2 to 3 scales that they can use to collect accurate INO, and the providers have bought into that. And again, I can't stress enough how education with the entire team is important. And with this education is to take out the myths that go along with catheter prevention. So, we continued looking at our catheter supplies, and we found a little hitch in one of the supplies that was brought in. Really was not always a closed kit in the way the kit was designed. So we, again, looked at other companies and decided on a kit that was standardized across the whole hospital for if you needed a temp probe or you didn't need a temp probe. And we included MRI in our issues, in our conversation, because they often have issues with temp sensing Foley, and we wanted to make sure everybody was on the same page with those guidelines. And then we also had the discussion around the QIN-QIO catheters, now that they make a closed kit, and how can we just use the QIN-QIO catheter. One of the things we also talked on a different note is that with every insertion, did it go smoothly or was it any pain or discomfort? And we can tell you over the last 6 months we've had 3,000 catheters that were inserted. And of those 3,000 catheters inserted, we know that only 110 had any pain or discomfort. And then we could further drill down to see who they were. And then our QIN-QIO catheter policy is going to be built on that data. We continue to do education and return demos for insertion, care, and maintenance across all disciplines. And we did a lot of work on what should our urine sampling, if we are going to do a urine culture. What are the indications for the urine culture? And when do you change out the Foley catheter? And as we've looked at the evidence, there is no strong evidence. Should it be 2 weeks? Should it be 48 hours? There's no standardization. So we here at Maine Med change the catheter out after 48 hours. So any catheter that is younger than 48 hours, we can take the sample from the port. Otherwise, we put a new catheter in. We've done a lot of work because there was a lot of blame. Oh, this really shouldn't be a CAUTI attributed to us. People don't understand at the bedside the surveillance definition. So we were able to work with staff so that they could understand the definition. And then we will also continue the weekly audit. Every week, there's peer-to-peer-to-peer review. Gee, I just looked at your catheter, and there's a kink in this catheter tubing. Let's fix it together. And it's taken us a long way to get there, but we collect that data and we report that data out on a weekly basis. We've gotten more lattice in it. And one of the things that we've really started to do is that we do an RCA on every infection. And we put the entire interdisciplinary team in the room to come up with the action plan for the infection, and then return the data. And we just started doing that a few months ago, and it has been very valuable. It is a whole different story than the CAUTI committee looking to see what the trends are versus the frontline staff to say, aha, this catheter really wasn't indicated. What could we have done differently? How could we have done things differently? How would our conversation take place next time when we're talking with you, the provider, or the nurse when the catheter has been ordered? And we found some success there. This slide here is just a sample of our manual bundle chart audit. We put it into Excel. We hand do all this data, and we send it back to the floor. We roll it up to why they have the catheter and to these components. And then we, on the action plan side, we can look at the areas where we've had weakness and we can work on it. For example, when we first started doing this, only 70% of our catheters had orders. Now we're at 95% of our catheters have orders. And by the end of the day, when we review, it's 100% because we get orders for every catheter that we have. So that was something we saw on this audit. And this is house-wide slide, and you can see how the catheter orders have been dropping off and how we working to get that back. And you can see over the period of time, the number of patients with catheters has significantly decreased. And we're very proud of that work. This year, as I mentioned, we added some additional rationale for our order set if the provider should order urinary catheter until provider discontinues. I can tell you that we had a meeting with the surgeons on Friday, and they said, why do you have those as indications? Those are the only indications for a Foley catheter. You should not be able to write in any other reason for a Foley catheter. And they really wanted to have free text. And we're saying, no, it needs to be one of those indications, and you need to tell us what the plan is. If the patient has a catheter and they don't have an order, one of the things we were able to do, which is in the best practice guidelines, is to put the hot stop so that they will get a BPA and they will need to answer the BPA. However, for those who have FS, at times you can bypass this, and that still becomes an issue. But at least we put that in. We talked about when we put in our indwelling catheter, we also wanted to begin to collect some other data. How traumatic was the insertion? How many times did we have to put the catheter in? Is there a link to our infection with the number of attempts? And so, because we were able to add these fields easily, we now can get that data easily. And it will help support technology that our urology department wants to purchase, which is a portable device that can be used in places cystoscopy to place catheters that are difficult. And that's part of the reason we took that here. Now, throughout this whole process, we've had to refine it several times. Staff often get very frustrated when you put a policy in place and then it may change, or that we may have gotten a new Foley catheter kit. We may have gotten a new straight cath kit. We have to tell them why we're doing it, and we can't give up. And I think if you can explain the why and have them as part of the decision and really make it a frontline decision, it will go much better. It has to come from the front line, and you can't give up, because with CAUTI, you have to keep refining your process. There's no one thing besides not having a catheter that can keep you from having CAUTI infection. So, we've now moved into 2015, and we have the sole goal of decreasing our catheters by 50%. Every single day, review every single catheter for appropriateness, and we send it to the front line and to the physicians. If there's any issues or concerns, I have a new physician co-chair with me who follows up with those individual physicians on a daily basis. And we're able to work with teams and coach them for alternatives to putting the catheter in and to think about the alternatives. The epic changes in the heart stocks the valve was put in. Our rounding has changed a little bit. We still go to the unit, but what we do is we go into the room and really look at the Foley bag. We look to see if there's any kinks. We look to see if the bag is on the floor. We answer patient and family questions. We look to see that we have the securement device on. And we just switched our securement devices, again, based on frontline recommendations for what is the best to use. And there we've brought in education a couple times around the securement device, because we don't want to cause pressure ulcers as a result of the securement device. The retention protocol. ANA and ANA in the end of January, actually 2015, has come up with new guidelines for catheter care, and they have recommended that two RNs are present on insertion, one to be the observer and one to be the inserter with peer-to-peer feedback. We are in the process of implementing that now. We have now rolled out education again, and we're doing a lot of work on educating on the appropriateness of the QIN-QIO catheter with the evidence. We've partnered with our laboratory committee, looking at all urine cultures across the hospital, outpatient, inpatient, not just with the catheter, even dipstick and even sediment, to see when they're appropriate. And again, that's a culture change, because of people, most of the time when we're investigating with CAUTI, we don't even know why the catheter was indicated. And you wonder if somebody had an infection on admission that is asymptomatic, especially in some of the elderly women. We continue education for all stakeholders, and we're continuing to look at new products for even urine cultures. We did try the test tubes, but the staff did not like it, so we're now going in a different direction. And again, this year, we have the definition changes that we're dealing with. Since I did this presentation, or the slides that you have in front, we have now changed this guideline to make it a little bit more clearer and to add some of the recommendations from the 2015 ANA guidelines. But really what we're trying to let the staff know is that you need to flash scan every 4 to 6 hours after removal of the catheter. Volume 300 to 500. If you have a small, short person, 300 is probably your max. If you have somebody who's 6'10", 500 is probably not even your max, but you need to use some critical thinking. You need to initiate a prompted void and monitor the straight cast as needed. We want people to straight cast for 24 hours and then have a conversation with the provider. We have had to add some language about what kinds of conversations should you have with the provider, what kinds of things should you be thinking about. For example, BPA, if they have a prostate issue, if they have constipation issue, if it's an epidural or narcotic issues, other medications, and to consider a urology or a pharmacy consult. And then again, if the patient has any bleeding, any discomfort, to notify the physician sooner, and then you can discuss the plan of action. And we also need to educate providers that we have alternative ways of checking INO. And then the last thing that we've changed on here is for the patient who may be voiding a frequent small amount, we changed that under 180 cc's to assess to make sure that they are not retaining. A helpful resource is this ANA toolkit that can be found at the link that is provided. It is a very well done, evidence-based tool. We were very happy to see it come out because it really supported all the work that we were doing here at the medical center. So, one of the other lessons learned, as you heard me say, is that we've partnered with other groups. We need to talk CAUTI all the time and to put it into all of the hospital strategic plans. It is not only about the infection, but it's a way to reduce costs, decrease length of stay, fall reduction, and delirium prevention. So there's a lot of benefits to not having a catheter and not having a CAUTI, and we need to talk about that all the time. So our team has really worked hard. It has been a lot of change and a lot of change in the culture, but we always have to keep our focus back on the patient. It has been somewhat of a rocky road, but everybody needs to be accountable for this initiative. We've been able to get funding because our leadership team is involved. We've been able to get providers involved, and that's why our catheter rates have gone way down. We've been able to get nursing and the support staff involved, and we've been able to get radiology and transport and TT and OT all involved in what the guidelines are. And most importantly, we've been able to celebrate this success as we continue our journey. So, I'm now going to turn it back to Danielle. Thank you very much.
Thank you, Ms. Chapman, for a great presentation. Before we open up the lines for questions, I just want to ask Ms. Chapman a question that was on the chat. They were wondering about literature to support a change from 16 French to 14 French. If you have that, you could share with everyone.
It's actually in the ANA guidelines now that say that you want to use the smallest possible catheter possible. And that's probably the best place to get it, to use the smallest. And I know that it's there, and I know that it's on the set.
Okay. Great. Thank you very much. If you have any questions at this time, please press *6 on your phone to unmute your line.
Hi, Danielle. This is Carol Dietz from Quality. I want to thank you for that outstanding presentation, Joanne. I have a question about your administrative support. You had talked in the very beginning about making sure that you had an administrator or somebody in the C-suite on board. Could you talk about which administrator you used? Did you use multiple? And how often did you communicate with them?
That's a great question. First of all, we now have a culture of safety committee that is run by the executives in the C-suite. It is chaired by our COO, our CNO, our vice president of the service lines is on that committee. I sit on the committee because of the culture of safety. Our patient safety officer is there. And that group now is the group where we bring issues, concerns, and barriers, and they help take that away. The backing up when we first started, I had the backing of the CNO, who actually held some CAUTI forms at the very beginning and backed everything that we did 100%, as well as the COO, because their goal is to have no infections, and we are a magnet organization, and they were behind us 100% of the way.
Excellent. Thank you.
Another question received on chat is, what is your facility size?
We are 637 licensed beds.
Okay, great. And
with an average daily census of about 520 per day.
Okay, excellent. There was another suggestion on the chat about the slides being sent out on a kind of a one slide per page, and we will send that out as well. Is there any other questions?
This is Amber from Porter Hospital. Could we get those slides also, please?
Yep, the slides will be sent out with the evaluation tomorrow.
Okay, great. Thank you.
I have a question. How do you count your catheter days?
Oh, we are still doing it manually. You notice the size?
Yeah.
So our goal is to have 3 consecutive months within 5% on every unit, and we can get to between 16 and 18 units a month, and we have not been able to get to all 22 units for 3 consecutive months within 5%. So what we do,
you want to record an epic?
we do. So we have at midnight, each nurse, or each team unit goes and does a manual catheter day. Who is physically in that bed and who has a catheter?
Okay.
At the same time, Epic is pulling anybody who's in the system that has an active LVA. But then in the morning, we get a report to what they've entered in the manual database and what they have entered into what's in the electronic database, and we get specific names, and on the units is supposed to rectify that.
Okay. Thank you.
Process. Same thing for central line.
Yeah.
But able to build a lot of reports to help units say, why did they count this one? And unfortunately, you know what happens? People forget to DC the central line.
That's where we think the biggest issue is that they have like 300 catheter days because they never DC'd it on their last admission.
So again, I'm fortunate. I have somebody that works for me full time who goes through every single catheter every single day, and if she sees that, she will DC it. And they don't have a catheter. She'll DC that LVA, so that doesn't keep happening. But today, in reviewing what might be a potential CAUTI, the question of infection control is, help me to try to decide when that catheter was discontinued. So I had to make a few phone calls, and the nurse had discontinued the LVA when the patient transferred, put in a note, DC'd when patient transferred, but she dated it on the 30th when the patient really transferred on the 27th. So there were 3 extra catheter days. And by going in and changing it, our report will change at the end of the month.
All right. Thank you. That's helpful.
There was another chat, this is Danielle, there was another chat question about root cause analysis. Do you have a tool that you use and share?
Yeah, so I will email to Danielle the fishbone that we use. We developed using the APEC guidelines. We really took the idea of the fishbone that you use when you start your CAUTI program of GAP and really developed it to what are the root causes for an individual. So we have a fishbone, and we use a formal RCA process, and we have an action plan template that we put together, and then we put all the root causes together and look at trends and make sure that our CAUTI committee action plan is working in the same direction as what these action plans are. It's really helpful when it comes from the front line because we can sit and review the chart and say, I think this is the root cause. But when they identify it, it becomes more powerful, and they're not going to let it happen again. And getting physicians in the room and providers in the room is key. It cannot be a nursing-only RCA.
Hi, Joanne. This is Carol again from Connecticut. And if you could just touch on how you were able to change the culture in the operating room for related to catheters that are not indicated for surgery under 2 hours in length. So that is huge. I'm just wondering how you even started that culture change.
So we were really lucky. We had an energetic rep from the OR, and we had a surgeon with us, and they took this on so that they had interdisciplinary team meetings to really say, it's going to be okay if we take it out, this is what we're going to be doing, and we started with one group at a time. It also helps when you have Joint Commission come in and survey your specific program, and I am fortunate enough that I get to tag along to those visits, and their celebrations. I think the Joint Commission coming is a really celebration of excellence at your institutions. If you can get your surveyor to say, well, what do you see in other hospitals? What do they do? And when they hear that the trend is not to put them in for the 2 hours, that has helped us because it's not only what we're seeing but the evidence, but you have an external set of eyes that are coming in saying you're writing guidelines of what everybody else is doing. So, and we had to reach out to one surgeon at a time, and having a surgeon as our partner has really made that, as a partner in the CAUTI prevention world has really made that helpful. I often just text him and I say, I have an issue, can you follow up on this? And he'll text me back. So it's we have a really great relationship, and he does follow up provider to provider with peer review. A couple of surgeons that are a little bit difficult, but you got to do a lot of work with them behind the scenes.
Thank you.
Okay.
Do we have any other questions?
There is a question in the chat box. Do you have any formal culture change processes in place, like team steps or CUSP on your unit?
So we do have a team step program and team training, and that has been big for a few years. And actually it started rolling out in the OR. And we have been investigating CUSP. We do have clinical transformation teams. We have unit-based consults that are multidisciplinary, but they're not formally CUSP. But we're looking to put in operational excellence and lean as the formal process. But people have bits and pieces of a lot of different things. We did have clinical microsystems here, which was big, and that was the other formal process that we used.
Okay. So thank you all for a great discussion. I just have a few last announcements before we end today. You will receive a follow-up email with a link to a very brief survey about today's webinar. We ask that you please complete it. Your feedback is very important and helps us to provide you with meaningful programs in the future. Within the next few business days, we will send out an email with everyone that will contain both the presentation and a recording of the webinar. And we'd like to thank you again for attending and hope you have a great day.
Thank you. Excellent job. Thank you so much.
Thank you.